Chronic obstructive pulmonary disease is a disease characterized by chronic respiratory symptoms and airflow obstruction. It also affects quality of life due to exacerbations and hospitalizations. The most common and most important risk factor remains smoking. Hence, interventions for smoking cessation are critical in COPD management. The long-term goals of management include the improvement of health outcomes and quality of life, reduction of symptoms, exacerbations, hospitalizations and mortality, and improvement of lung function. Signs and symptoms. Consider COPD in adults with a history of smoking and presenting with persistent and progressive respiratory symptoms such as difficulty of breathing, cough, and phlegm production. Screening. Screening for COPD is not recommended in asymptomatic adults. Assess patients with symptoms of probable COPD using a clinical scoring system to identify patients for confirmatory testing. Diagnostic tests. Minimum at primary care. Confirm the diagnosis among probable COPD patients by using the combination of a clinical scoring system and handheld spirometry as alternative to facility-based spirometry. Examples of a clinical scoring system are the COPD Diagnostic Questionnaire, CDQ, COPD Population Screener, COPD-PS, Lung Function Questionnaire, LFQ, COPD Assessment in Primary Care to identify undiagnosed respiratory disease and exacerbation risk screening tool, CAPTURE screening tool. Do not use clinical scoring system, handheld spirometer, or peak flow meter alone to confirm the diagnosis. COPD is confirmed if there is non-fully reversible airflow limitation, FEV1 over FVC less than 0.7 post-bronchodilation. Gold standard. If available and accessible, request for the gold standard facility-based spirometry to confirm the diagnosis. Refer to a higher-level facility for this test if necessary. Initial assessment of confirmed COPD. Consider determining the following 4 fundamental aspects in COPD assessment among those confirmed with COPD by spirometry. Severity of airflow limitation, nature and magnitude of current symptoms, previous history of moderate and severe exacerbations, and presence and type of other disease, multimorbidity. Classification of confirmed COPD. Classify the patient's symptoms according to the Modified Medical Research Council Dyspnea Scale to identify the appropriate treatment. MMRC classification. Symptoms. MMRC 0, dyspnea only with strenuous exercise. MMRC 1, dyspnea when hurrying or walking up a slight hill. MMRC 2, walks slower than people of the same age because of dyspnea or has to stop for breath when walking at own pace. MMRC 3, stops for breath after walking 100 yards or 91 meters or after a few minutes. MMRC 4, too dyspneic to leave house or breathless when dressing. Treatment. Start treatment in all adults who have COPD. Pharmacologic management of stable COPD. First-line therapy. Choose the appropriate therapy according to the FEV1 and MMRC classification of the patient. FEV1 greater than 80% or MMRC less than 2 and not in exacerbation, LAMA monotherapy. FEV1 less than 80% or MMRC greater than 2 and not in exacerbation, LABA-LAMA combination therapy. If LABA-LAMA combination therapy is not available or accessible, use LAMA instead of LABA. FEV1 less than 80% or MMRC greater than 2 with increased risk of exacerbation and absence of concurrent respiratory infection, add an inhaled corticosteroid ICS on top of long-acting bronchodilator LABD. Examples: LABA-LAMA ICS or LABA ICS plus LAMA LABD. Second-line therapy. If inhaled long-acting bronchodilators, examples LAMA, LABA, are not available or accessible, offer oral methylxanthines. However, long-acting bronchodilators remain preferred over oral methylxanthines. Methylxanthines include thiophyllene and doxophylline. Pharmacologic management of COPD in exacerbation. First line, administer short-acting beta-2 agonist SABA plus short-acting antimuscarinic antagonist SAMA combination. If SABA plus SAMA is not available, administer SABA alone. Add-on therapy. If the patient in exacerbation has worsening symptoms and does not respond to bronchodilators, SABA plus SAMA or SABA alone, give a short course of oral steroids 5 to 10 days. Refer patients with COPD in exacerbation to higher levels of care as necessary. Management of bacterial co-infection in outpatients with COPD exacerbation. Initiate oral antibiotics in patients with COPD who present with at least 2 of the following symptoms: increased dyspnea, increased frequency of cough, increased sputum volume or purulence, Anthonson's criteria. Antibiotic options to complete course in 5 to 10 days, 2018 National Antibiotics Guideline. Amoxicillin 500 mg 3 times a day. Doxycycline 100 mg tablet 2 times a day. Cefuroxime 500 mg tablet 2 times a day. Non-pharmacologic management. Smoking or vaping cessation in current smokers or vapors. Develop a COPD action plan with the patient to be used for self-guided management. Referral. Refer patients with COPD who have any of the following conditions which are associated with higher risk of moderate to severe exacerbation to higher level of care. Prior history of exacerbations, presence of comorbidities, severe or very severe airflow limitation. Refer patients with COPD who have any of the following conditions which are associated with higher risk mortality to higher level of care. Presence of uncontrolled diabetes or cardiovascular disease. Previous hospitalization for acute exacerbation within the past year. Hospital readmission within 30 days. Use of long-term oxygen therapy. Palliative care. Consider giving low-flow oxygen therapy to relieve dyspnea in symptomatic COPD patients with moderate to severe breathlessness, MMRC 3 to 4, who are not hypoxemic and who do not fulfill the criteria for long-term oxygen therapy, LOTT, provided it is used with caution and the patient is closely supervised. Consider giving opioids, examples morphine, to relieve dyspnea despite maximized medical managements in patients with advanced stage or end-stage COPD and/or refractory dyspnea, presence of uncontrolled diabetes or cardiovascular disease, previous hospitalization for acute exacerbation within the past year, hospital readmission within 30 days, use of long-term oxygen therapy.
Summary of recommendations. Clinical practice guidelines for the management of chronic obstructive pulmonary disease. Among smokers, we recommend smoking cessation to prevent COPD. Among patients with COPD who are smokers, we recommend smoking cessation to prevent COPD-related morbidity and mortality. Among households using biomass fuels, we recommend shifting to clean fuel, that is, gas or electricity, to reduce the risk for COPD. Among probable COPD patients, we recommend against the use of clinical scoring system alone compared to facility-based spirometry in confirming the diagnosis of COPD in the primary care setting. Among probable COPD patients, we suggest the use of clinical scoring system to identify patients who may need further confirmatory testing. Among probable COPD patients, we recommend against the use of peak flow meter alone in confirming the diagnosis of COPD in the primary care setting. Among probable COPD patients, we recommend against the use of handheld spirometer alone in confirming the diagnosis of COPD in the primary care setting. Among probable COPD patients, we suggest the use of combined clinical scoring system and handheld spirometer as an alternative to facility-based spirometry in confirming the diagnosis of COPD in the primary care setting. Among probable COPD patients, we suggest against use of combined clinical scoring system and peak flow meter compared to facility-based spirometry in confirming the diagnosis of COPD in the primary care setting. Among stable COPD patients in the primary care setting with FEV1 less than 80% or MRRC greater than or equal to 2 and are not in exacerbation, we recommend the use of LABA-LAMA combination therapy over LAMA or LABA monotherapy. Among stable COPD patients in the primary care setting with FEV1 less than 80% or MMRC greater than or equal to 2 and are not in exacerbation, we suggest the use of LAMA over LABA. The Modified Medical Research Council Dyspnea Scale stratifies severity of dyspnea in respiratory diseases, particularly COPD. MMRC of 0, dyspnea only with strenuous exercise; MMRC of 1, dyspnea when hurrying or walking up a slight hill; MMRC of 2, walks slower than people of the same age because of dyspnea or has to stop for breath when walking at own pace; MMRC of 3, stops for breath after walking 100 yards or 91 meters or after a few minutes walking on the level; MMRC of 4, too dyspneic to leave the house or breathless when dressing or undressing. Among stable COPD patients in the primary care setting with FEV1 greater than 80% or MMRC less than 2 and are not in exacerbation, we suggest the use of LAMA monotherapy over LABA monotherapy or LABA-LAMA combination therapy. Among stable COPD patients in the primary care setting with FEV1 less than 80% or MMRC greater than or equal to 2 with increased risk for exacerbations and absence of concurrent respiratory infection, we recommend the use of inhaled corticosteroids in combination with inhaled long-acting bronchodilators. Based on included RCTs in this review, addition of ICS to long-acting bronchodilator was indicated for patients with recurrent history of exacerbations. However, concurrent respiratory infection was identified as a contraindication. Among stable COPD patients in the primary care setting, we recommend the use of inhaled long-acting bronchodilator over oral methazanthines. Among stable COPD patients in the primary care setting, we recommend the use of oral methazanthines versus no treatment if inhaled long-acting bronchodilator is not available. Among stable COPD patients in the primary care setting, we recommend against adding oral methazanthines to inhaled long-acting bronchodilator. Among patients with COPD, we recommend the use of SABA plus SAMA in the management of acute exacerbation. In situations where SABA plus SAMA is not readily available, SABA may be used. Among COPD patients in acute exacerbation with worsening symptoms and not responding to bronchodilators, we recommend the use of short-course oral steroids in the primary care setting. Short course is 5 to 10 days. Referral to higher level of care may be done upon discretion of the primary care physician at any time for non-responders or for those with incomplete response. Among outpatients with COPD, we recommend initiation of oral antibiotics in the presence of at least 2 of the following symptoms: increased dyspnea, increased frequency of cough, increased sputum volume or purulence. Among COPD patients managed at the primary level, we recommend referral of any of the following conditions that are associated with higher risk of moderate to severe exacerbation to higher level of care: prior history of exacerbation, presence of comorbidities, severe or very severe airflow limitation. Among COPD patients managed at the primary level, we recommend referral of any of the following conditions that are associated with higher risk of mortality to higher level of care: presence of uncontrolled diabetes or cardiovascular disease, previous hospitalization for acute exacerbation within the past year, readmission within 30 days, and use of long-term oxygen therapy. Among stable COPD patients, we recommend the use of guided self-management utilizing COPD Action Plan in the primary care setting. Among symptomatic COPD patients with moderate to severe breathlessness, who are not hypoxemic and does not fulfill criteria for long-term oxygen therapy, we suggest using low-flow oxygen therapy for relief of dyspnea with caution and close supervision of attending physician. Moderate to severe breathlessness is defined as MMRC of 3, stops for breath after walking 100 meters or stops after a few minutes walking on the level, or 4, too breathless to leave the house or breathless when dressing or undressing. Among patients with advanced stage or end-stage COPD and/or refractory dyspnea, we suggest to consider the use of opioids with close supervision to relieve dyspnea that persists despite maximized medical management. The Fagerstrom test for nicotine dependence, a 6-item questionnaire that measures physical nicotine dependence. Total score, 0 to 10. Most important question, time to first cigarette after waking, strongest predictor of dependence. Scoring interpretation, 0 to 2, very low dependence. 3 to 4, low. 5, moderate. 6 to 7, high. 8 to 10, very high. Clinical use. Score greater than or equal to 5, consider pharmacotherapy, NRT, bupropion, or varenicline. Higher score, greater withdrawal severity and relapse risk. That would be all. Thank you, and God bless.